hear me? Hello?
Right. Okay. Can you hear me now?
Yeah, I can hear you. I'll just give an introduction of your
All right.
background. Following by that, we can start this one. Sajid is one of my close friend in Ottawa. We did our fellowship together in Ottawa, Canada, and he has done his MD from Father Muller's College in Mangalore. Followed by that, he worked in Kerala, and then he moved to Australia for a year, and then to Canada. Did his program fellowship in Canada, and also he has been trained in TN echo, targeted neonatal echocardiography, and has been right now working in as a clinical neonatologist in Windsor Regional Hospital, and also he is an assistant professor in University of Western Ontario. He is a great academician, and also he has published a lot of systematic reviews. His special interest is in stem cell therapy and bronchopulmonary dysplasia, where he has done a largest collection of studies on preclinical studies on BPD and stem cells, and has been published in Stems Translation Medicine Journal. In addition to that, he has a number of quality improvement programs, as well as he does a lot of audits in his own unit, and has been a great game changer for during the fellowship, as well as a clinical associate as of now. Thank you, Sajit, for accepting our invite and coming to present in our forum. And I think it will be a great enlightening experience for us to know about chronic bronchopulmonary dysplasia and pulmonary hypertension. Over to you, Sajit.
Awesome. Thanks, Srini. Thank you for those kind words. I don't think I deserve any of that. But yes, Srini has been a very good friend. And thank you for scheduling me at 6:30 in the morning in Canada. Thank you so much. All right. So getting to the topic right away, all right. So the objectives of for one, examine BPD associated pulmonary hypertension, understand the underlying pathobiology of it, describe of early pulmonary vascular disease. And I'm sure some of this might have been addressed in the previous presentations on pulmonary hypertension. I would address this from the perspective of preterm BPD associated pulmonary hypertension. And then we will eventually discuss the role of screening of hypertension and the screening and diagnosis, and touch upon novel therapeutic agents in the or prevention of pulmonary hypertension. With this regard, talking only about stem cell. I will not be talking about other areas which may help in the management of pulmonary hypertension, and I'm sure those have been discussed in previous during these webinars. When we look at screening, universal screening in ICU, this may be true. This is true in Canada. This is true in North America. This may be true in India too. We screen our preterm babies for multiple preterm complications. So when you look at the network, this is a database of in Canada. Application during the NICU stage. 500 babies were born less than. Also know that a majority of these had a neuroimaging done. And because of that, we know that around 15% of these babies had an intraventricular hemorrhage. For the same cohort, we know that almost half eye exam for retinopathy of prematurity. And because of that, we know that around 8% of these had more than had stage 3. And from the same report, we also know that the same cohort had 944 cases of BPD, and formally at 36 weeks. But do we know how many of them had BPD associated pulmonary hypertension? We don't. So there is definitely there. Now, what does literature say? This is from Peter Morani, a day where he and his team abstracted data from the Korean cohort, the Alabama cohort, the Korean cohort in blue, the Alabama and the Colorado and the Indiana University cohort in yellow. As you can see, and this is what you see on the x-axis is BPD based on severity, and what you see on the y-axis is the percentage of patients. So as you can see, you could, from all these three cohorts, you could either have severe BPD, you're more likely to have mild BPD, and quite a number of go home without a diagnosis of BPD. Now, how many of these, based on BPD associated pulmonary hypertension? So again, from study, if I can draw your attention to the severe, from the Korean cohort, more than half of these babies had pulmonary hypertension in severe BPD. Same was true for the Alabama cohort, and around 30% of the Colorado cohort had BPD associated pulmonary hypertension. The incidence was lesser in moderate BPD and quite less in mild or even no BPD. Now, what about the entire cohort? So regardless of the severity of BPD, I would draw your attention to the right portion of this chart. 1/4 of the babies in the Korean cohort had BPD associated hypertension, while 14 to 17% from the Alabama and the Colorado cohort had BPD associated hypertension. So it's quite clear that although we are quick and probably proactive in making a diagnosis of BPD, somehow the associated morbidity of pulmonary hypertension, BPD associated pulmonary hypertension is missed, and you could probably try as the tip of an iceberg. What's the incidence of BPD associated hypertension in Canada? But if I would superimpose our BPD rates based on severity on the previous cohorts, our rates of severe BPD are quite similar to the one from Colorado and Alabama. We probably have more numbers of no BPD and higher numbers of moderate BPD. So my guesstimate is that our rates of BPD associated hypertension are no different than from our neighbors down south or from Korea. Now, this is a systematic review from 2017, where they did a systematic review and literature search from January 2000 to December 2015. And they found that the pooled incidence of BPD associated hypertension was 24% in the moderate to severe category, and 1/3 of the severe BPD had BPD associated hypertension. Now, overall, the pool incidence, regardless of the category, was 17%. And there was a higher likelihood, a higher chance that there was BPD associated pulmonary hypertension with severe BPD than without. 6 to 8 folds higher likelihood of, or higher odds of having BPD associated with pulmonary hypertension. Bring us to my next objective as to why this happen. Why does pulmonary hypertension occur in BPD? So you may be familiar with this. This is a seminal paper from more than a decade ago by Bernard Thibault, who also is my research mentor out of Ottawa. So he, I think he published this with Steve Abman, and essentially describing the biology of pulmonary hypertension. So as you can see, type 2 alveolar epithelial cells, they produce vascular endothelial growth factors, and these vascular endothelial growth factors bind to signaling receptors on the endothelium. And this stimulates not only alveolarization, but also angiogenesis. So vascular endothelial growth factors are important mediators in both alveolar development and angiogenesis. Now, in the same paper, he hypothesized, and this is based on the Cox postulates, that VEGF signaling, if inhibited, would result in a phenotype of bronchopulmonary dysplasia where there is alveolar simplification. Conversely, if you look at experimental BPD or even human BPD, there was diminished levels of vascular endothelial growth factors. If vascular endothelial growth factors was overexpressed or reactive, then alveolar architecture was restored. Now, what is clear from this understanding of pathobiology is the lung vasculature in BPD undergoes or performs a vanishing act. We know that preterm birth results in an incomplete growth of the vasculature, and whatever vasculature develops is immature in function. So we know that preterm babies have decreased antioxidant defenses. There is also hypothesis that there are epigenetic and genetic factors which modify development of lung circulation. And of course, there is emerging evidence that placental dysfunction can or will modify the developing lung circulation in a preterm. Now, on top of this, you add in, on top, you add in all the things that we do in the neonatal period, which will cause lung injury, such as oxygen administration resulting in hyperoxia, mechanical ventilation causing lung injury, infection because of, say, chorioamnionitis or PTROMs, inflammation, hypoxia, and the ubiquitous hemodynamic perturbations of the preconductus arteriosus. So all this has impact on the developing lung circulation in the preterm. And what result? So it can result in three main outcomes as lung circulation and lung vessels are concerned. These vessels have an abnormal structure or a deranged architecture. They can have an abnormal function. And they are decreased in number. So when I talk about abnormal architecture, I'm talking. So this is essentially a 3D microvascular reconstruction of age-matched controls and age controls of BPD. So what you see on your left is a normal perinatal lung. This is the airway. This is the pulmonary veins. And this is the bronchovascular bundle with the lymphatics and such. And what you see on the right panel, 3 and 4, you see all these yellow vessels here. So these are vessels. So then these are intrapulmonary arteriovenous between what is the bronchoarterial bundle, and you can see that it proceeds towards the pulmonary, which is in blue, right? And you don't see this in the normal lung. So clearly there are new micro vessels which are established, or these are shunts which are established in bronchopulmonary dysplasia, which is unique to BPD patients and normal lungs. So what is the purpose and what's the function, or what is the result of these shunts? And again, what you see from the synthesis paper from the American Thoracic Society, what you see on the left side is the normal lung, and what you see on the right side is the PD lung. These shunts or micro vessels are off in a normal lung. So the deoxygenated comes in the proximal limb, gets oxygenated, and then in the limb, it goes into the pulmonary vein, which is rich in oxygen. So there is no hypoxemia. But in the BPD lung, these shunts open up, and the blood is bypassed and results in hypoxemia because of the shunt. So clearly, this causes the hypoxemia in BPD, and that explains the need for oxygen. Now, function, we say the lung function is deranged. So this is a study by Steve Abman. So Steve Abman has published seminal literature on BPD and BPD-associated pulmonary hypertension. This was one of his first papers from 1985, where he looked at 6 babies or 6 kids with BPD who underwent a cardiac catheterization at a median age of around 2 years or around 25 months. And as you can see, as you can see, what's on the x-axis is arterial oxygen saturation, and what's on the y-axis is the pulmonary arterial pressure in mmHg. If oxygen sats are less than 80%, the mean pulmonary arterial pressure in these 6 kids are around 48 mmHg. But as soon as you increase, and what you see is the hatched box, pulmonary arterial, and as soon as you increase the arterial oxygen saturation, there is a dramatic decline in the pulmonary. 48, it drops down to 25 in an arterial oxygen saturation between 80 to 100%. So clearly, the vascular tension, the vasoreactivity is responsive to oxygen, and the pulmonary vasculature is reactive. So this proves that the vascular tone is increased, and there is increased vasoreactivity, and there is probably some hypertensive remodeling of the pulmonary vasculature. The tunica adventitia and the tunica media are hyperplastic. And of course, there is, as I said, there is a hypothesis that the blood vessel number, the pulmonary blood vessel number are decreased, and decreased angiogenesis. Now, what does it, so we or the architecture of the lung vasculature is deranged. We have examined why, or is there any derangement in the lung vasculature function? What about what does this mean for the lung mechanics? So this again is a study from 2010, published in the American Journal of Critical Care Medicine, Respiratory and Critical Care Medicine, where they looked at pulmonary diffusing capacity on the y-axis with in to body length. So these were 39 babies who were less than 29 weeks. who had a pulmonary diffusing capacity measured at around 1 year of age. And what you can see is the solid dots are chronic lung disease infants, and the empty dots or the empty squares are controls at 1 year of age. And you can see the pulmonary diffusing capacity is lower in the chronic lung disease infants as opposed to the term control. So clearly the lung mechanics are deranged. And of course, this is after you adjust for body length. So structure deranged, lung function mechanics are also deranged. There is clear evidence is associated with pulmonary hypertension, but does early pulmonary hypertension predict the occurrence of BPD? Because you would not make a diagnosis of BPD before 36 weeks post-menstrual age, and sometimes pulmonary hypertension is present quite early during the neonatal course. So does it mean that a preterm baby who has pulmonary hypertension is more likely to develop BPD? So this is a study of over 120 babies who were less than 20 weeks. This was published quite recently in Journal of Pediatrics, where they looked at this cohort, and they found that the incidence of pulmonary hypertension, early pulmonary hypertension during the first 2 weeks of life was 8. And the total incidence of moderate to severe BPD in this cohort of 120 was around 50%. So 50% of these babies developed moderate to severe BPD. But what about the babies who had early pulmonary hypertension, the 8% who had early pulmonary hypertension? Almost all of them, almost 90% of them had moderate to severe BPD. Now, what about the not have early pulmonary hypertension? 47% had 7% developed moderate to severe BPD. So clearly, if you have early pulmonary hypertension, you are more likely to develop moderate to severe. And this is a presentation of the pulmonary hypertension or the pulmonary vascular disease based on gestational age. So you can see that more preterm you are, more likely is the incidence of pulmonary hypertension. And this drops the gestational age with each additional week of gestation. So having pulmonary hypertension predisposes to having BPD, and BPD is associated with pulmonary hypertension. What about mortality? And we always, when you look at outcomes, we talk about or BPD. So what about pre-discharge mortality? So the mortality send this baby home from the ICU. So what we know from study published in 2017 is, again, this is a meta-analysis of 3 studies, and they found that when in comparison to BPD only, babies and pulmonary hypertension had a higher odds, up to 5 times of higher odds of dying in the ICU before being discharged home. What does it mean? Once they go home, what's the chances of survival? Again, this is a study more than a decade ago where 40 babies were followed up until 2 years of age following the discharge from the ICU. And for the entire cohort, you can see that 50%, what you see on the y-axis is the probability of survival, and what you see on the x-axis is the months of pulmonary hypertension. So at the age of 2 years, 50% of them survived. But I would draw your attention to the severe pulmonary arterial hypertension category, where only 30% survived at 2 years of age, while this is in stark contrast to 70% in the mild pulmonary hypertension group. So you're less likely to survive if you have severe pulmonary hypertension, while the chance of survival is around half if you have any form of pulmonary hypertension. Now, so about chances of death before discharge from the ICU, the chances of death once you're discharged from the ICU. But what does it mean if baby survives beyond 2 years of age? What does it mean for long? So this again from Peter Murani. Peter Murani and Steve Habman, if you look at BPD associated hypertension literature, these two have published a significant amount of papers on topic. So again, this is a more recent study from 2019 where they looked at long-term outcomes, especially respiratory for babies who had a mean gestation age of 27 weeks. So they recruited 221 neonates and followed them up into childhood. And they found that if severe BPD, the odds of having late respiratory, so late respiratory disease includes asthma, bronchiolitis, respiratory infections. All this was increased up to 3 times if you had severe BPD, and almost 2 times if you had moderate or BPD. So, well, so it's clear that BPD associated hypertension, you end up with having a higher chance of having pneumonia or asthma or acute BPD exacerbations or any respiratory related hospitalizations if you are less than 27 weeks. What does it mean if you are an adult and you're an ex-preterm? So this again is some recent study from 2018 where they looked at around 11 adults who had an average gestational age of 28 weeks. And what you can see is, so they looked at these adults underwent cardiac cath, and they had their mean pulmonary arterial pressure measured. They also had their total pulmonary vascular resistance measured. So what you see on the x-axis are the term as opposed to the preterm, and what you see on the y-axis in the first panel is the mean pulmonary arterial pressure, mmHg. So you can see that, and the solid red line is 2 standard deviation, and the dashed lines are 1 standard deviation. So you can see that the preterm babies tend to have pulmonary arterial deviation which are 2 standard deviations above normative values as opposed to term babies. So they have higher pulmonary arterial pressures or pulmonary hypertension. What about vessel stiffness? Again, tend to have mean pulmonary arterial pressures higher than normative levels as compared with term babies. Now, this is about pulmonary vessels, their pressure and their stiffness. What about cardiac function? So again, preterm babies tend to have, again, the solid line is 2 standard deviation, or the solid line is cardiac dysfunction. So preteens tend to have cardiac function as opposed to term babies, and again, elastance, their vessels are stiffer as opposed to babies. Now, so it's clear BPD associated hypertension have short-term morbidity in terms of higher risk of mortality, but also long-term morbidity, which goes into childhood and even into adulthood. So it's clear that we need to screen these babies, which we are not doing a great job about. So we need to screen them and we need to diagnose them. So the tools which are available to us in screening and diagnosing BPD associated hypertension are ECHO and cardiac cath. Now, this is a really old paper from 1985, probably one of the first studies, which had pulmonary arterial measurements, simultaneous measurements with an echo and also the catheter. So the patient would go into the cath lab, would have a catheter, would have a catheter inserted into the right ventricle, and then have simultaneous measurements of the pulmonary arterial pressure with Dopplers. So I would draw your attention to panel A. What you see in the upper part of this panel is the catheter pressures, catheter readings in the right ventricle. So the right ventricle is reading 117, and as you withdraw the catheter, you're in the right atrium and gradient of 104. Now, if you look at the Doppler envelope, it is 100, and it's clear that there's the catheter or the Doppler. 100 on the catheter, sorry, 104 on the Doppler. Now, what you see on the right panel is, well, this is a child who is in atrial fibrillation. So if you take the fourth wave, the catheter measures 87 in the right ventricle and a gradient of 64. While the Doppler envelope measures RVSP of the right ventricular systolic pressure of around 66. So it's clear that there is high correlation between a catheter and the Doppler when. And again, this is a study from same author who looked at around 111 subjects, and they found almost 9 between pulmonary arterial pressures measured by the catheter, which is on the x-axis, and the pulmonary arterial pressures measured by means of a Doppler, which is on the y-axis. So 96% is very high. If you look at all diagnostic tools, 96% correlation is high. But what happens when you measure? What happens when you measure consecutive? What happens when you measure consecutive pulmonary arterial pressures? So you see that the correlation drops dramatically. From 96%, it dropped down to 19%. So again, what you see on the x-axis is pulmonary arterial pressures measured by catheter, y-axis seen by echo, and it is all over the place. So it was also found in the study, and this is a more recent study, pulmonary arterial was estimated in only 61% of echoes, and echo was able to identify the presence or absence of pulmonary hypertension in only in 80% of the ones in which pulmonary arterial pressures were measured, and the severity was correctly identified in only half of this. So 2/3 of all subjects were able to be identified to have pulmonary arterial hypertension by means of an echo. A large majority, if you did identify pulmonary arterial hypertension, a large majority would find presence or absence of pulmonary hypertension. And if you identify pulmonary hypertension, half of these were correctly identified based on severity. Again, from the same paper, if you compare diagnosis with echo diagnosis, so what you see on the x-axis is the cath, and what you see in shaded boxes or the shaded column, diagnosis by echo. So the white box is no pulmonary hypertension, the black box is mild to moderate pulmonary hypertension, and the gray box is severe pulmonary hypertension. So you can see that if well, the CAT diagnosis with the gold standard, that diagnosis was severe pulmonary hypertension. One subject was diagnosed as no pulmonary hypertension, while subjects were characterized as severe hypertension, which was in agreement with the CAT diagnosis. Same is true for mild to moderate. Most subjects were identified correctly by the echo. one subject who was diagnosed to have pulmonary hypertension. All to say that there is no great correlation between echo and cath in the diagnosis of pulmonary hypertension if measured consecutively, as opposed to when you see high degree of correlation when measured simultaneously. So despite this, Society and the American Heart Association came out with joint guidelines in 2015. These were published by Steve Abman in Circulation. Despite the shortcomings of echo as a screening tool, they still recommend screening of pulmonary hypertension by echo in every baby who has established. So if you make a diagnosis of BPD at 36 weeks, you subject that preterm to a challenge test, and you make a diagnosis of mild or moderate or severe BPD, then that baby should have a pulmonary hypertension screening by echocardiography. Further, from the Pediatric Pulmonary Hypertension Network in 2017 came out with these recommendations. And amongst these are that multidisciplinary team consisting of neurologists, pulmonologists, cardiologists, intensivists, and pulmonary hypertension specialists should be involved in the care of BPD-associated pulmonary hypertension, provide a comprehensive and consistent approach. They recommend cardiography if there is hypoxic respiratory failure, if there's a continued need for ventilatory support at postnatal day 7. So, or to pick up those early pulmonary hypertension cases, because early pulmonary hypertension can manifest even as early as day 10. So this is a diagnostic of BPD-associated pulmonary hypertension from the same pediatric pulmonary hypertension network. So you determine severity of BPD at 36 weeks post age. If you make a determination of no or mild BPD, you monitor, and then if there is failure to improve or worsening of respiratory course, you can perform a comprehensive cardiogram, echocardiogram. But if you make a diagnosis of moderate to severe BPD, then you should be performing an echo right away. And of course, if there are signs of severe respiratory disease, if there is hypoxic respiratory failure, there are signs and symptoms of pulmonary hypertension at any stage in the NICU course, then it makes a lot of sense in performing an echocardiogram sooner. And based on echo, you make a diagnosis of whether there is pulmonary hypertension. There is no pulmonary hypertension. So there are qualitative measures, there are quantitative measures. Measure you use if you determine that the echo parameters are less than half of systolic arterial pressures, then you can safely rule out pulmonary hypertension. But if it is anywhere between half to 2/3 of systemic pressures, then you make a diagnosis of mild to moderate pulmonary hypertension. And then if your pulmonary pressures on echo are more than 2/3 of systemic, then you make a diagnosis of severe pulmonary hypertension. So, okay, so we know there is a significant incidence of pulmonary BPD-associated hypertension. We know what are the long-term, short-term, and long-term consequences of having BPD-associated pulmonary hypertension. And we know there are recommendations from the American Thoracic Society and the American Hypertension Network, screening guidelines with respect to echo, but how many of us comply with these guidelines? So I don't have literature from or data from India, but what I can show you is data from North America. So these were 112 respondents or neonatologists responding to the survey, and it's a more recent survey in 2019, and 21 neonatologists from Canada who shared that a very large majority of them do screen associated pulmonary hypertension. Half of them do have screening protocols, but only 1/3 of them have a management protocol in place for BPD associated pulmonary hypertension. And although they have, many of these centers do have, they rarely use them for the BPD associated pulmonary hypertension. The evidence is still emerging. There is a lot of unknowns here. There is a lot of poor compliance with respect to these guidelines. And I think there is a lot of work to be done. Now, this brings us to the final section of my presentation, novel therapeutics. And as I said, I would be talking only about stem cells. And by stem cells, I mean mesenchymal stromal stem cells. Mesenchymal stromal stem cells. So recent research has revealed the biology of stem cells and the therapeutic potential of it. Can self-renew. They can differentiate into specialized cells, which promote organogenesis, which can regeneration, maintenance, and repair. And especially mesenchymal stromal cells has attracted attention and particular interest because of their use of isolation, expression, their apparent multipotency, and their pleiotropic effects on multiple injury models, lung injury models, cardiac injury models, brain injury models. So if mesenchymal stromal cells, and this is in an animal model, if they were introduced into the airway or were administered by IV in hypoxic lung injury models, what you see, again, these are lung models from a rodent. Left, this is a normoxia model. Lung injury with oxygen causes simplification of alveoli or air spaces, and administration of stromal cells reverses this simplification to a near normal alveolar architecture. The bottom panel, the lung vasculature. So extreme left is lung vasculature in a normal lung. Toxic conditions, hyperoxia or BPD causes vascular pruning, right, decreased number of lung vessels, and treatment with mesenchymal stromal cells restores lung vasculature or angiogenesis. Inflammation. Treatment with MSCs by intratracheal route or intravenous route causes. So what you see here, so this is the BPD lung and the inflammatory markers here, macrophages and neutrophils in oxygen, and then treatment of reduces the number of macrophages and neutrophils. What about pulmonary hypertension? So the same study, the lung animal model study, where you see Dopplers in the top panel here. So this is the right ventricular systolic pressures, or the pulmonary arterial pressures under normoxic conditions. In BPD lung, typical notching of pulmonary hypertension and narrowing of the envelope, and treatment with MSCs in this BPD lung returns the envelope to a near normal level, and with a control cell. Bottom panel, what you see on the y-axis is pulmonary arterial acceleration. So the pulmonary arterial acceleration times in BPD lungs, the PATs are diminished because, well, there is pulmonary hypertension. So the blood which is pumped into the pulmonary arterial circulation goes in with increased pressure and takes less time to go in because of the pulmonary hypertension. Treatment with MSCs restores the PATs to near normal level. So this is normoxia PATs, and this is treatment with MSCs. Hypertrophy. We know right ventricle is hypertrophic in pulmonary hypertension. So y-axis, right ventricular thickness, x-axis, this is BPD lung. You see there is increased RV, LV ratios. Treatment of MSCs reduces this thickness. So we performed a meta-analysis, a systematic review and meta on the preclinical therapeutic efficacy of MSCs in BPD and BPD associated pulmonary hypertension, and we found that treatment with MSCs definitely offers a so there was benefit when as opposed in BPD as opposed to controls. We published this last year. We looked at all the novel stem cells out there used in the treatment of animal models of BPD and BPD associated hypertension. And we found that in comparison with controls, mesenchymal stromal cells and mesenchymal stromal cells therapeutic agents, but there were other agents which were also being tested, such as human epithelial cells, endothelial colony forming cells, and endothelial colony forming cell derived condition media. So how do these cells compare head-to-head comparison? So again, when it comes to BPD associated pulmonary hypertension, we found that all these cells, well, not all, MSCs and ECFCs provided benefit as opposed to a controlled intervention. So yeah, so that's the end of my presentation. I was hoping to do this, but I don't think I don't know how to set up a poll, but maybe Srini, can you? Is there any way we could do this in terms of audience responses?
The chat box.
Sorry.
They can respond in the chat box.
Okay. Okay. All right. So, okay. So let's look at post-test quiz, as I would say. The incidence of pulmonary hypertension in severe BPD has been found to be A, 2 to 5%, B, 13 to 16, C, 30 to 50. Yeah, I don't think this will. Yeah. So yeah, I guess some people, some people have got it right. 30 to 50% in severe BPD. 17% is the pooled incidence if you look at any type of BPD. Yeah. Most of you have, all of you have got it, in fact. Okay. If BPD associated pulmonary hypertension is not characterized by intrapulmonary for that type of the intrapulmonary arteriovenous anastomotic shunts, hypoplasia of tunica intima, lower pulmonary diffusing capacity, increased pulmonary vasal reactivity. Few minutes there. So not characterized by. Yes, so I see two responses. Yes, both of them are right. All these are seen in BPD associated pulmonary hyperplasia of tunica intima. You typically see hyperplasia of tunica media and tunica adventitia. You do not see hyperplasia of tunica intima. We saw why or how pulmonary anastomotic shunts open up. We know that pulmonary diffusion over in childhood in babies who have BPD associated pulmonary hypertension, and we also know that they have increased pulmonary vasal reactivity. Okay. Echo in a 26-week preterm should be performed if a diagnosis is made at 36 weeks post-menstrual age, B, day of life 7, C, non-invasive ventilation, and on 40% FiO2 on day of life, I think 28. D, A plus B, E, all the above. Yep, the answer is all the above. This is the recommendation from the Pediatric Pulmonary Hypertension Network 2015. The following regenerative therapies have been found promising in pulmonary hypertension: A, endothelial colony forming cell; B, mesenchymal stromal cell; C, human amniotic epithelial cell; D, exosomes.